Hello and welcome to Talking About Tumors with Ryan and Ryan. I'm Ryan Holstead.
And I'm Ryan Quinn.
And today we're going to carry on our discussions around advanced non-small cell lung cancer, today with a focus on the driver mutations.
Hope everybody had a good weekend. Happy Canada Day to all the Canadians out there, and happy July 4th to the Americans in the audience. Also, congratulations to everybody that graduated residency and fellowship on July 1st. I know I graduated fellowship and I'm very excited.
And thanks to all of you who provided feedback, whether that's from emails or ratings on the various podcast apps. We really appreciate it. Last time we spoke around the basis of chemotherapy and immune checkpoint inhibitors for advanced non-small cell lung cancer. And we've multiple times mentioned that it's very important to check for next-generation sequencing, molecular targets, as this can inform decision and potentially provide a non-chemotherapy option that may provide better outcomes overall. The mutation that's had a predominant and major effect on the outcomes of patients with non-small cell lung cancer is the EGFR mutation. This makes up about 15% of all non-small cell lung cancers. However, there's many other less common mutations that have their own directed targeted therapies. So today, because of the prevalence, EGFR is going to be the majority of our talk, with ALK being also deriving a good portion of the discussion.
One thing that's good to know is that these mutations are usually mutually exclusive. So if you have an EGFR mutation, it's pretty unlikely that you'll also have an ALK mutation or RAS mutation. And next generation sequencing, as Ryan said, is the preferred way to check for these mutations now. In the past, they were done using FISH or immunohistochemistry, but now it's usually kind of more broad-based next generation sequencing, although this can change depending on where you're practicing.
I think the point about these mutations being mutually exclusive is pretty important. You know, something that's truly a driver mutation that causes lung cancer to form on its own should be able to do this in absence of other major driver mutations. You know, this is in contrast to one of the mutations like P53 or maybe BRCA, where there ends up being a cascade of multiple mutations that form. These EGFR positive and ALK positive lung cancers do tend to have a lower tumor mutation burden. This is relevant because it will get into whether or not these are likely to respond to immune checkpoint inhibitors. And in fact, EGFR mutations are typically considered to be resistant to the benefit of immune checkpoint inhibitors and have been excluded from modern trials.
So getting into EGFR, EGFR is part of the HER2 family of proteins, which has an extracellular domain, a transmembrane structure, as well as an intracellular tyrosine kinase domain. What happens with EGFR mutations is that this protein gets constitutively activated and causes increase in cell proliferation, decrease in apoptosis, increase in angiogenesis. There are specific mutations that can cause kind of the inappropriate activation of this, and we'll get into some of them. The most common being mutations in exon 19 and exon 21. It's also important to note that with EGFR, as well as some of the other driver mutations, these are really mostly seen in lung adenocarcinoma, so it's pretty rare for it to be seen in squamous.
Yeah, there's certainly a debate on whether or not running these NGS panels are as important in squamous carcinomas. And if you did have a EGFR positive squamous carcinoma, there remains some question of how clinically relevant that may be and whether or not it's going to derive as much benefit.
Yeah, I know where I was practicing, if somebody is a non-smoker, we'll still check this in squamous cancers, but it's not very common.
Now, as mentioned, this is, at least in North American populations, present up to 15%. Typical board-style question is going to describe a young female non-smoker of Eastern Asian descent. And this is because in the Eastern Asian population, these are much more prevalent, these mutations. In many of the earlier clinical trials, and EGFR inhibitors were situated in Asia.
So even though this is seen mainly in non-smokers, these mutations can actually also happen in smokers just because of how common smoking is. So I wouldn't let a smoking history make you not check for these driver mutations.
The agents that are currently available are separated into what's called first generation, second generation, and third generation. First generation are predominantly erlotinib and gefitinib. These were initially studied in all non-small cell lung cancers and did show some efficacy as later line with modest benefit. But as biomarkers for EGFR mutations became developed, we were able to better select the patients who are most likely to benefit from these treatments. So how we got to the understanding that there were specific mutations most likely to benefit was found in a trial of gefitinib. This was a pan-Asian study, and this was looking at gefitinib, and what they did post-hoc was looked at all the different mutations and found the ones that were most most likely to benefit. And in fact, the two that Ryan had mentioned, the exon 19 deletion and the exon 21 L858R mutation, were the most likely to provide a significant improvement in outcomes. And these two mutations are very important and actually became the only two that were approved for first-generation inhibitors in the United States. Although many trials were run using gefitinib and erlotinib, a couple things worth noting is that overall, patients had much better survival than EGFR negative patients, whether or not they received chemotherapy or targeted agent. We saw an average overall survival in this population from 20 to 25 months, which was very good in the pre-immune checkpoint inhibitor era.
So the EGFR agents as a class have similar toxicities. The most common thing that we see is rash. So anything from like dry skin to the development of acne, which can be bothersome to the patient and is pretty common. Gastrointestinal toxicities are also common. So things like diarrhea is common. They can also cause liver injury with elevated LFTs. They can all cause pulmonary toxicity. One interesting toxicity, which you'll see rarely and sometimes can appear on exams, is an ocular toxicity where eyelashes actually start growing in towards the cornea, which can cause a lot of irritation to the cornea and can also cause dry eyes. They can also cause conjunctivitis as well. So any ocular toxicity, you should make sure that you refer the patients to ophthalmology.
I've had patients who initially get a little bit actually excited when they hear that one of the side effects is that their eyelashes might grow longer, but unfortunately, when this does occur, it can be actually a medical nuisance.
Many of these toxicities can actually be much worse if the patient has recently received immunotherapy. It's not very common that someone would receive immunotherapy right before starting one of these agents, but if that is the case, you actually have to delay for at least 3 months because these toxicities can be much more severe. This is also important to know because if you're waiting for this testing to come back and you're considering starting immunotherapy, you might want to think twice because if you give immunotherapy and it does come back positive for EGFR mutations, then you'd have to wait, again, at least 3 months before starting.
Yeah, you'll occasionally run into a scenario where a patient has very aggressive disease, is in the hospital, and you're considering giving a course of therapy to start to lead to a response prior to discharging them. If you are in that setting, give just chemotherapy alone, because if you have that NGS come back 2 weeks later and it's EGFR positive, it's much nicer being able to start your EGFR agent right away rather than waiting 3 months with less effective therapy. These side effects are all what we call on-target, off-tumor effects. So these are EGFR targets, whether or not that's skin, the GI tract, the eyelashes, where these receptors are present elsewhere. And depending on how selective and strong the EGFR inhibitor is, you may have more or less level of toxicity. Fatigue and nausea can also be present. In the case of osimertinib, which we'll get to, as this is kind of the standard of care first line, QTc prolongation is relevant. If you do run into a patient who has a moderate to severe acneiform rash, there are often going to be protocols available at your institution, or perhaps if you're to look online with a combination of a cortisone cream and an antibiotic such as erythromycin that can often lead to clinical benefit in these patients.
So the first drug to be studied was gefitinib in the IPASS trial, but there is also another first-generation EGFR TKI called erlotinib. This also showed an improvement in progression-free survival when compared with carboplatin gemcitabine chemotherapy. PFS was 13.1 months versus 4.6 months, with the overall response rate of 83% versus 36%. Interestingly, there was actually no overall survival benefit seen, but given the significant PFS benefit, erlotinib is another FDA-approved agent for EGFR mutated non-small cell lung cancer and has similar side effects to gefitinib that we just described.
So although these drugs had improved progression-free survival with variable overall survival benefits, some of the difficulties interpreting the overall survival is some of the earlier studies didn't exclusively include exon 19 deletion, exon 21 L858R mutations. However, it became soon apparent that there was multiple resistance mechanisms that could develop. By far and away the most common, approximately 50% of patients developed what's called the T790M mutation, so another substitution mutation. There's some other secondary mutations that could form. The second most common was called MET amplification, so the MET protein is overexpressed in the resistant cells. Less commonly, but worth knowing and certainly board relevant, is small cell differentiation, and this often presents as a rapid progression of disease. It's should you have suspicion for this, you see the disease start to behave a lot differently, may be worth biopsying, because your approach to treatment is going to be very much different if you're dealing with a small cell lung cancer than an EGFR positive non-small cell lung cancer. In the era where we were starting with first-generation EGFR inhibitors, and in many places this still is the standard of care for first line, and progressions noted, it's valuable to know whether or not there is a T790M mutation. This can be done by either biopsying the tumor that's progressing, or if you have access to circulating tumor DNA, there are assays out there now to specifically test for this mutation in the blood. This matters because the newer or the third generation inhibitors, such as osimertinib, work on T790M, as well as some of the other substitution mutations. The drug osimertinib initially had shown benefit for patients who progressed with the presence of this mutation, and due to the fact that sometimes progression, such as in the brain or near critical organs, can prevent the initiation of second-line agents, osimertinib was then studied in comparison to first-generation EGFR inhibitors in the FLORA trial.
So once the third-generation EGFR TKI osimertinib started being used, there was questions whether or not this would be more effective in the first-line setting when compared with the first-generation TKIs, erlotinib and gefitinib. This was studied in the FLORA trial, which, again, compared standard of care, erlotinib or gefitinib, a physician's choice, versus osimertinib. Now, this study did allow patients with brain metastasis. The primary endpoint was progression-free survival, which was longer for the osimertinib group, 18.9 months versus 10.2 months. And there was also an overall survival benefit, 38 months versus 31 months. And when looking specifically at patients with the brain metastasis, there was better CNS efficacy with the osimertinib group. Osimertinib also had actually less adverse events. So when looking at anything above grade 3, there was 34% versus 45% with the first generation TKIs. So because of this trial, osimertinib was approved for frontline, and if you have access to it, it's the standard of care for first-line EGFR mutated patients.
So a couple things to note here that is certainly exciting. One thing is looking at the overall response rates. We don't talk about this too often because ultimately overall survival matters most, but when you're talking about target agents, it's nice to know how likely it is that your disease is going to respond to the therapy. And whether or not someone got first generation or third generation, response rates were above 75%, which is very high. 80% with the osimertinib arm, 76% with the erlotinib gefitinib arm. Comparatively, when we're talking about chemotherapy and other versions of non-small cell lung cancer, even in the immune checkpoint arm, we're talking about around 40 to 45% response rates. So very likely to respond in these EGFR positive cancers. Also, with an median overall survival of 38.6 versus 32 months, this is still very good outcomes regardless of which arm patients are on. One notable limitation to this trial, and one of the major criticisms of it, is that the patients in the first generation arm, only about 32% ended up getting osimertinib in the second line. This is not because many of these patients were not candidates for second line therapy. In fact, 65% overall did get some form of therapy later on. However, most of these patients got chemotherapy rather than osimertinib. This is probably because this was a global study and they did not have access to osimertinib in the second line. And unfortunately, where the primary question of the study was, is it better to give osimertinib first or save it for second line? That question was not actively pursued in the way the study was designed. Regardless, the sheer overall benefit and general tolerability of osimertinib has led this to be the standard of care in the first line setting in areas where there's access to this. However, if you're in a place that does not have access to this, you're still giving a good effective therapy to your patients with a first generation EGFR inhibitor. So we talked about first generation and we talked about third generation EGFR inhibitors, but what about second generation inhibitors?
So both second generation TKIs, afatinib and decomitinib, which irreversibly binds mutant and wild type to EGFR. These both were compared to platinum doublets and did show benefit. They were modestly superior to the first generation TKIs, but much more toxic, which is thought to be because of the fact that they're irreversibly binding EGFR.
Another limitation, at least in the terms of afatinib, is that the overall survival benefit over first-generation EGFR inhibitors was only seen in exon 19 deletions, not L858R mutations. And I think given the toxicity and the fact that these are still not as efficacious of a third-generation agent, they do not have efficacy in T790M mutations, they've had to find sort of more of a niche. And afatinib in particular did run a subgroup analysis of its trials and found that there was efficacy in some of the more uncommon mutations. And there's 3 that are considered: one S786I, one L861Q, one G719X. Either of these mutations seem to have benefited ifatinib and not in any of the first generation or third generation evidence that's available. So at least from my experience, that's where we've been using these most, in these uncommon mutated EGFR non-small cell lung cancers. One other notable EGFR mutation, although less common, are the exon 20 insertions. There's agents that are in early phase development with some data out already, primarily in the second line setting. So if you do have a patient who has an exon 20 insertion, this does not mean they're going to respond to any of the agents we spoke about so far. And you would typically proceed with chemotherapy first, but be aware if there's any clinical trials in the first line setting or at the time of progression, any clinical trials that may be available to your patient, as this is an open area of interest right now.
So the second most common driver mutation is an ALK rearrangement, which is seen in about 5% of non-small cell lung cancer. The rearrangement leads to a fusion oncogene. The characteristic mutation is a chromosome 2p inversion, which results in the fusion of the EML4 protein with ALK and causes constitutive tyrosine kinase activity. Similar to EGFR, this is seen mainly in adenocarcinomas and usually younger patients with never or light smoking history.
It's worth mentioning that fusion proteins are often very good targets for molecular agents, and you'll often hear about very good response rates as cancers that are dependent on fusion proteins are very sensitive to therapy. Examples that you may come across would be the Philadelphia chromosome, the NTRK fusion, which is rare but very sensitive, and the ALK fusion that we're speaking about here. And in the case of ALK mutations, many of the trials that are out there have shown response rates that are exceeding 70%.
So the first agent to be approved was crizotinib. This was initially studied in heavily treated patients and then moved up to second line when it was compared with docetaxel, and then was studied in first line when it was compared with a platinum agent and pemetrexed. Did have a higher response rate, 74% versus 45%, and improvement in progression-free survival, 10.9 months versus 7 months.
A follow-up publication that's translated into a 4-year overall survival improvement of 56% versus 49%, with the median overall survival not reached versus 47 months. Very importantly, 85% of the patients in the chemotherapy control arm ended up getting crizotinib. So this overall survival benefit was seen even when the majority of people on chemotherapy progressed and then got the agent in the second line.
So toxicities for crizotinib, which also apply to the other ALK-targeted agents that we're going to speak about, they're pretty well tolerated. The main things that we see are GI toxicities as well as fatigue and edema. Crizotinib also has a notable visual toxicity. The visual toxicity with crizotinib can be visual disturbance such as seeing flashing lights.
One toxicity word that I ran into when reviewing this trial, which reminded me that I didn't know what this word was before starting oncology, is the word dysgeusia, which is the bad taste that people get on systemic therapy. And although we typically think about that as maybe being the metallic taste that you get on chemotherapy, some of these targeted agents can provide the similar sensation, where people tell us that things just don't taste right or taste metallic-y or maybe less salty. Rarely could also include pneumonitis, with more selective agents, which we'll get to in a moment, having a higher risk of that. So, as with EGFR inhibitors, there are now second and third generation ALK inhibitors that exist. These, in general, are more selective overall for the ALK protein. Crizotinib is what we call a dirty TKI, where combined to multiple proteins. These more selective agents are also have improved CNS penetration. Difference between the second and third generation agent is the third generation agent is not only more selective, but also gets around some of the most common resistant mutations that lead to resistance to either first or second generation ALK inhibitors. All of these second and third generation ALK inhibitors have only been compared to crizotinib in the first line, and none have been directly compared to one another.
So the 3 second-generation TKIs are ceritinib, alectinib, and brigatinib. Of note, ceritinib is less preferred although these have not been directly compared to each other, it seems like there's less efficacy with ceritinib as opposed to brigatinib and alectinib. So that one has kind of fallen out of favor.
The only thing worth mentioning for ceritinib, which is a pharmacology question that could be high yield for the boards, is that food has a significant impact on its absorption. The first trial was actually looking at patients using a 750 milligram dose, but then a follow-up pharmacology-based study found that when eating with a fatty meal, giving a dose of 450 milligrams lead to equivalent efficacy and significantly less toxicity. So although the drug, as Ryan mentioned, does not have as impressive PFS findings overall, it does show that some of these agents really are impacted by what we're eating. It's good to know for many of these targeted agents interactions with other medications and food.
Alectinib has the longest follow-up data. In the ALEX trial, looking at first-line alectinib versus crizotinib, the progression-free survival was 34.8 months versus 10.9 months. The overall survival data is actually still immature, but it was not reached with alectinib versus 57 months with crizotinib. But we're waiting for the follow-up for further data.
There's also a much better CNS control rate, which is clinically relevant in these patients. Alectinib also has studies in addition to the ALEX trial. They have a trial named the J-ALEX trial that was only run in Japan, and the ALESIA trial, A-L-E-S-I-A trial that was run throughout Asia. Once again, there's no direct head-to-head between alectinib and brigatinib. Looking at the preliminary PFS data, it seems to be fairly similar, which is to say substantially better than crizotinib first line, and that has led to these two agents being the preferred first line for ALK-positive non-small cell lung cancer at this time.
Another notable toxicity for alectinib in particular is myalgias, which usually resolved after about a month of treatment on its own, but something to warn the patients about when they start it. The notable thing for brigatinib is that it can be associated with pneumonitis and pulmonary toxicity. One way to get around this is to do what we call step-up dosing, where you start, the dose is 180 milligrams, but you start at 90 milligrams for 1 week and ramp up to 180 milligrams. This is because you can have early pulmonary toxicity after the first few doses when you start at the 180 milligram dose of brigatinib. This generally appears as respiratory symptoms and ground glass opacities on imaging only after a few doses of brigatinib, but seems to be better tolerated if you do the step-up dosing.
These agents also seem to have a little bit less nausea and vomiting than the first generation. Third generation ALK inhibitors have been trialed. The one that's currently has FDA approval is lorlatinib. The lorlatinib agent was approved based upon a first-line study comparing this drug to crizotinib. As with the second generation agents, has not been compared directly to any of those. This did show improvement in progression-free survival and has previously shown a fairly good response rate in second line or greater, with a response rate of 40% in patients who've progressed either on a first or second generation ALK inhibitor. So it is efficacious in those that progress due to its ability to inhibit some of the more common mutations that can arise. Also has very good CNS penetration. I think time will tell whether or not it's better to be given in the first line or not. One of the main holdups to this getting a lot of traction in the first line space is its toxicity. And with lorlatinib, we do see high rates of hyperlipidemia, in fact, clinically relevant hypertriglyceridemia, hyperglycemia, and patients can develop TKI, and this has to be really closely monitored, especially in patients with baseline diabetes. And some very strange CNS toxicities, because it's so penetrant for CNS, and which is good if you have brain-related metastases. This drug can cause confusion, delirium, and vivid dreams. Have been reported by patients on these drugs, such as like nightmares, and can be quite disturbing. So given all that, because it has not yet shown to be better overall either in progression-free survival, overall survival response rate over the second generation agents, I haven't seen it used too much in first line myself.
So the next few mutations are not very common, so we're not going to spend as much time delving into each individual agent. Hopefully we don't bore you too much with this laundry list of agents, but these are important to know both for boards and for clinical practice, although they might not come up that often.
It's worth being aware of whether or not they have evidence in the first or second line to have a general understanding how likely the tumors are to respond to these mutations as well.
So starting off is ROS, which is in about 1% of patients with non-small cell lung cancer. And the two drugs are crizotinib, which we've already spoken about in ALK-mutated patients. This was studied in the upfront setting, and the progression-free survival was 19.2 months with a response rate of 72%. There's also another ROS inhibitor, entrectinib, which showed similar response rate of 67% with a progression-free survival of 15.7 months. So these are both approved for the first-line setting.
There's no phase 3 data here, and in general for many of these mutations, there's no phase 3 studies yet published just due to the rarity of the mutation themselves. Another relevant mutation is the MET mutation. This is on the RAS pathway. We've previously discussed the amplifications as being a common cause of resistance of EGFR positive disease. There's also some focal mutations that can arise. The most clinically relevant one is the exon 14 skipping mutation. Have some targeted drugs with approval, one capmatinib and tepotinib. These have also shown objective response rates of about 70%. Progression-free survivals of about 12 months, with toxicity such as edema, nausea, and vomiting. Crizotinib has shown some efficacy for these exon 14 skipping mutations with the response rate of about 30%. The amplifications do not yet have targeted drugs approved in the space, with lots of trials ongoing.
So if you remember from our melanoma talks, BRAF mutations, this is also relevant in non-small cell lung cancer and are seen in about 2 to 4%. The difference between this and some of the other mutations is that these actually tend to occur in patients with significant smoking history. If you remember from melanoma, the mutation was the V600E mutation. This is actually only seen in about half of BRAF mutated patients in non-small cell lung cancer, so not as common as in melanoma. So similar to melanoma, the combination of the BRAF V600E inhibitor and MEK inhibitor, dabrafenib and trametinib is also approved in the first-line setting with a response rate of 60% and a progression-free survival of about 10 months.
BRAF positive non-small cell lung cancer does seem to be sensitive to immune checkpoint inhibitors, unlike some of the translocations and mutations that we've discussed above. HER2 is another mutation that can be targeted in non-small cell lung cancer, also uncommon, in 1% or less of the population. The initial trials that looked at adding trastuzumab onto chemotherapy with some progression-free survival, although not very impressive. More recently, small trials have looked at the antibody-drug conjugates and found maybe improved objective response rates of about 40 to 50% with both trastuzumab deruxtecan and trastuzumab emtansine. Very small trials. I wonder about what the risk of pneumonitis is from people who are getting trastuzumab deruxtecan, because if you recall, that's a risk of that medication. Worth mentioning for HER2, these are specifically studied. The way that the mutation study works is looking for an exon co-insertion mutation, and is not reported as a 2+, 3+ in many of the assays that are out there right now. Also worth mentioning that the antibody-drug conjugates for the HER2 have been studied in second-line settings. So this is after progression on a chemotherapy, platinum-based chemotherapy regimen.
So the last mutation that we want to talk about is the KRAS G12C, which is glycine to cysteine mutation at amino acid 12. And the drug that is used for this is called sotorasib. This was studied in the CodeBreak study, which I'm sure if you're on Twitter, it's been a little bit controversial. It was a phase 3 trial in patients that had previously received a platinum doublet plus or minus PD-L1 inhibitor, looking at sotorasib versus docetaxel. They did find a progression-free survival benefit, 5.6 months versus 4.5 months, so only about 1 month different. And the overall survival was similar in both groups.
The overall survival came out at 10.6 versus 11.3 months, so the survival is actually a bit longer in the chemotherapy arm. Hazard ratio is 1.0. The development of RAS inhibitors actually brought a lot of excitement to the field. This was previously a protein that was thought to be undruggable, with early pharmacology studies finding that there's really no binding pocket for the most common drug development assays. However, the generally frequent G12C mutation had changed that. And the initial phase 1 trial did show a very good response rate of about 30% with sotorasib. So when the phase 3 trial did report out, there was a lot of excitement that we found a targeted agent on a previously undruggable protein. And even though that benefit was small, it's hopefully a window to better drugs to come down the pipeline. I think one of the main questions is this drug clinically relevant in this setting for our patients? And there's certainly some questions about that. The overall survival doesn't seem to be much improved. The counterpoint, of course, being is this less toxic than docetaxel? Docetaxel is a somewhat toxic chemotherapy with neuropathy, nausea, vomiting. The study did do a standardized quality of life analysis. It's worth mentioning that for a quality of life analysis, it's important when the survey was run. I'm not sure when it was run from this. It's not really specified in the protocol. It's very possible that you could run a survey about a week after someone receives chemotherapy, and that's usually when they're feeling unwell, versus if you run it the week before they get their next cycle of docetaxel, they may feel very well, versus someone on sotorasib might be feeling not so bad, but persistently a little unwell for the whole course of treatment. I think overall, though, it does look like the toxicities were a bit less, and that is certainly in the favor of a targeted agent. Costs will be limiting for many locations. This is about a $15,000 a month drug I've seen quoted some places. And for a drug that does not improve survival over old-fashioned chemotherapy, I think it might be hard, especially in patients with such a limited life expectancy of the order of 10 months on clinical trial patients, may not be funded in many countries where that is a relevant factor.
There is one other KRAS inhibitor that is approved for the G12C mutation, which is adagrasib. This is approved for patients that have received one prior line of treatment. This was looked at in a single-arm study with a progression-free survival of 6.5 months and overall survival of 12.6 months. So it can be an option in the second line for patients with this mutation.
So certainly a disease space with a lot of new drugs coming out, a lot of new mutations coming out, and nothing's changed more rapidly than the targeted landscape of non-small cell lung cancer. Many of these trials have been published, later than 2010. Good to keep in mind what you do after someone's progressed on your agent if they're still a candidate for systemic therapy. So let's say they progress through a third line or third generation EGFR agent or a first, second, and third line ALK inhibitor or one of the other agents mentioned. Next line, usually if they have not received a platinum doublet, would be giving a platinum doublet regimen. Be mindful of which of these mutations might be sensitive to immune checkpoint inhibitor or not, and certainly incorporate that if you have access to it and if it is a sensitive mutation. One thing that I didn't mention last discussion, but is also worth mentioning in the after progression of the platinum doublet, there is at least some evidence to incorporate ramucirumab with docetaxel. If you have access to this, docetaxel and ramucirumab did improve overall survival in the second line setting after progression on platinums by about 1 month. That is probably not significantly relevant, but if you have access to these medications, it does not add a whole lot of toxicity and may slightly improve survival for your patients. Because this is a rapidly developing field, be aware of clinical trials in your area that may be targeting one of these mutations that we've discussed above or one of the new emerging mutations that we did not have time to get to.
Okay, so bottom lines for the driver mutations, starting with EGFR, depending on where you're practicing, the standard of care would either be first line osimertinib, which is the third generation TKI, versus using one of the first generation TKIs, erlotinib or gefitinib, and if they progress, checking for the T790M mutation, and at that point, switching to osimertinib. If your patient has an ALK translocation, you consider starting with alectinib or brigatinib if you have access to it. Otherwise, crizotinib is still an acceptable first-line agent. At the time of progression, to consider incorporating a third-generation ALK inhibitor, lorlatinib, but be mindful of the toxicities with this, which can include hyperglycemia, hypertriglyceridemia, and CNS disturbances. Although these agents are well tolerated and have similar toxicities, it's good to be aware of the differences between them. The other mutations, again, are much more rare, so you probably won't see these as often. So on that note, everybody, thank you for listening and have a great weekend. We'll be moving into the localized setting next, and hopefully we'll be able to continue to provide some good conversations around that. Bye for now. Take care. For more information, follow us on Twitter at Talking Tumors, or feel free to email us at talkingabouttumors@gmail.com. Please rate and review the podcast. We really appreciate it. And special shout out to our friend John Kim for all of his musical talents. And he is the composer of the music that you're hearing right now. Talking About Tumors is not medical advice. For medical advice, please contact your own healthcare provider. Opinions stated on this podcast are by the Ryan who said it and no one else. We have no financial disclosures, and this is done purely on our own time to the sake of our enjoyment of the field of medical oncology. Thank you for listening, and see you next time.